No, she's not. She's not.
Okay, so we are starting with the okay, we've started with the protozoa already. I think we stopped at cryptosporidium. So we'll talk about the protozoa that causes the CNS infection, and there are three. That's Toxoplasma gondii. I know we are very familiar with this one. This is not the first time we are hearing this. There's Naegleria fowleri, and there's Trypanosoma brucei. So Toxoplasma gondii is one of those protozoa that cause CNS infection, particularly in people that are immunocompromised. So if somebody that is immunocompetent or someone that is okay with respect to the immune status get infected with Toxoplasma gondii, they just have mononucleosis-like symptoms like headache, um, um, myalgia, lymphadenopathy, body ache, malaise. That's just what they have. They don't really have any specific illness like that. And if you do this heterophile antibody test, so this heterophile antibody test is just to separate causes of infectious mononucleosis. So you see somebody that's having headache, that's having sore throat, that's having myalgia, lymphadenopathy, maybe there is splenomegaly too, and you are thinking, oh, is this infectious mononucleosis? If you want to know the cause of that infectious mononucleosis, you want to do this heterophile antibody test. So the summary of this test is that they are just taking horse red blood cells. So red blood cells of that is gotten from horses. So they combine them with the serum of an individual with the infectious mononucleosis. So if the cause of that infectious mononucleosis is from EBV, Epstein-Barr virus, there's going to be hemagglutination. So it's like Epstein-Barr virus infection causing infectious mononucleosis produces this heterophile antibody that can cross-react with red cell antigens that are derived from us. I don't know if that do we get that? Does it make sense to us? So you get red cell antigens from horses,
Yeah.
you mix it with some serum of somebody that has infectious mononucleosis from EBV, there's going to be a reaction. So that is the heterophile antibody test. Now, if that infectious mononucleosis is from CMV, there won't be any reaction. CMV can cause something that looks like infectious mononucleosis. So you can differentiate between EBV, that's human herpes virus 4, and human herpes virus 5, that's CMV, causing infectious mononucleosis. You can separate them by doing your heterophile antibody test. So someone that is LD, that is infected with Toxoplasma gondii, having mononucleosis-like infection, you want to be sure, is this due to maybe one of those EBV or something? If you do your heterophile antibody test, it will be negative. So you know that, oh, this is likely to be CMV or Toxo. So you can now further continue with your test. But it's not the usual presentation because most of them will be asymptomatic. So, but Toxo is very bad in people that are very, very immunosuppressed, particularly people with AIDS, especially when the white blood cell count is like less than 100 cells. I mean, the CD4 is like 100, so they are highly predisposed to developing Toxoplasma gondii infection. I think I've seen it once. I've seen a case once of a patient having this Toxoplasma gondii infection in the brain. So they primarily affect the brain. They can affect other organs, but the most worrisome one is actually the brain. So that's why we are focusing on the CNS one now. So the brain. So what you see is that they are going to have multiple ring enhancing lesions. So once you see multiple ring enhancing lesion on MRI, one of your differentials should be a brain abscess from Toxoplasma gondii infection. So yeah, so that's very important. Most of the time, other differentials for ring enhancing lesion includes maybe primary CNS lymphoma, but in most setting of lymphoma, you are going to single lesion. It's not going to be multiple. Once it's getting multiple, you are thinking of like infectious process like maybe toxo or your neurocysticercosis. But if it's single, it's likely to be maybe a tumor like primary CNS lymphoma. So there's something we also call congenital toxoplasmosis because toxoplasmosis as an infection can be transmitted from the mother to the child. So a baby that gets infected with toxoplasmosis in utero, how do they present? So the way I mastered it is the three C's. Three C's. So the first C is the chororetinitis. So there is like calcification and inflammation affecting the the retina, as well as the choroid layer. That's the middle layer of the eye. So there's chororetinitis. The second one is the intracranial, so cranial calcification. So cranial calcification. Then the third one, so that one doesn't typically have the C, but you just have to remember, just focus on this cephalus, so hydrocephalus. So chororetinitis, cranial calcification, and hydrocephalus. Three things for toxo. How do they get this toxo ideally? So because you tend to find this toxo um, plasma gondii protozoa within the muscles of cats. So they can form cysts within the muscle of the cat, and it typically exists in two forms. So you have the brachyzoid and the tachyzoid. So I don't really want to emphasize more on that so that we'll not be wasting time. We should not be wasting time. But the one that stays within the muscle primarily are the brachyzoid. The one that can be in the muscle as well as in the blood or the CSF is the tachyzoid. So that's just another name for um, trophozoite. So the trophozoite form of Toxoplasma gondii is the tachyzoid. So yeah, so within the cat muscle you find the brachyzoid. Within the blood fluid of the body fluid of the cat you find the tachyzoid there. So you can release the oocyst in cat feces. So you have the gametes from the brachyzoid. They can differentiate into the male and the female gametes. So they proliferate together, the lay eggs. It will develop into the oocyst. So the oocyst can be shared in the feces of the cat. So another person can take up, that another animal rather can take up that cat feces. Maybe another cat eat it again. So that oocyst is now going to differentiate into the brachyzoid that will the tachyzoid first. So the tachyzoid will be free living in the blood, the CSF. They can go to anywhere. The tachyzoid will also differentiate into the brachyzoid. So the brachyzoid will be the latent form that will stay in the muscle or the brain. They will just be there, inactivated. So once the immune suppress, so that's for the cat. So you can have the tachyzoid now differentiate to the male and female gamete. They copulate together, they form the oocyst. The oocyst is shed in the stool. So the cycle continues like that, like that. That's how they transmit from one cat to another cat. Now let's now say that an human is exposed to maybe the cat meat, or an human is exposed to a food that is contaminated with the oocyst of the cat feces. So that means that once the oocysts get into the person's intestine, it can differentiate into both the tachyzoid and the brachyzoid. So the tachyzoid can differentiate into the brachyzoid. The brachyzoid will go to the muscle and the brain and hibernate. Once the immunity is suppressed, all your brachyzoid cannot be converted into the tachyzoid. So they'll find their way into the blood and they'll start causing the damage. So they can go to the brain and start causing, you know, seizures, paralysis, focal neurologic deficit, anything you can think of, anything you can think of. So that is that. So two ways or three ways is either a man takes in the food that is contaminated with the oocyst, or the person eats the meat of cat that contains the brachiozoids. So the person takes in the meat of cat that contains the brachiozoid that is within the muscle. Or a pregnant woman is exposed to those oocysts. So within the pregnant woman, the person can, the oocysts can differentiate to the tachyzoid, and the tachyzoid, like we've said, that's the one that you find in the blood. That one can travel across the placenta to the baby and cause infection in the baby. So three routes. You can ingest it, by taking food that's contaminated with the oocyst. You can eat the meat that contains the cyst. The meat will not contain oocyst, but the cyst, which is a brachiozoid. Then you can transmit it from mother to child. So the tachyzoid in the mother can go to the fetus. So you always want to advise pregnant women to avoid cat litters. They should not touch anything related to cats so that they don't get contaminated with the feces and um, absorb the oocyst. So how do you want to make the diagnosis? You can just do serology. You are looking for antibodies against the toxo, or you can just do biopsy of the muscle. You see your tachyzoid there. We've said it that tachyzoid can be found in the muscle, it can be found in the brain, it can be found in the blood, CSF fluid, anything. But your brachiozoid is only in the muscle and the brain. latent, not active. So if it wants to cause infection, it has to differentiate into the statuoid. So how do you want to treat? So what I used to learn is just SP. So sulfadiazine pyrimethamine, SP, SP, sulfadiazine pyrimethamine. That's the treatment. But for prophylaxis, particularly someone with CD4 count less than 100, you want to give Septrin. So same thing for someone that has pneumocystic jirovecii, CD4 count less than 200, you want to give Septrin prophylaxis. Although there are so many things that we can use. You can use Septrin, you can use Dapsone, you can use pentamidine, atovaquone, any many things. But for Toxo, your Septrin is for your prophylaxis when the white blood cell count is less than 100, but your major treatment is SP, sulfadiazine, pyrimethamine. And you guys know that these drugs are folate inhibiting drugs. So you want to give this woman folinic acid when you are giving this medication. The most important thing to remember here is actually okay, the mode of spread. Those three modes of spread, they can ask you any one of them. What you are going to see in someone that is infected and the person is immunosuppressed. So the person can have a brain abscess. Then, thirdly, the triad of the congenital toxoplasmosis. The three C's: tracheal calcification, the calcification, chororetinitis, and hydrocephalus. So they commonly test three um, congenital stuff. So they test congenital CMV, congenital toxo, congenital rubella. So we already know congenital rubella from our what's it called from our CVA. So someone that has a PDA, someone that has cataract, someone that has sensorineural deafness. So PDA, cataract, sensorineural deafness. That is congenital rubella. Although it's more than that, but those are the classic findings. For CMV, CMV is very, very similar to Toxo. Very similar to Toxo. They have this chororetinitis, but they don't have intracranial calcification. Instead, they have periventricular calcification. So their own calcification is surrounding the ventricles, not the cranium, which is a bone, like Toxo. So it's the cranium itself that is calcified in Toxo, but it is the ventricle within the brain that is calcified in CMV. CMV, um, congenital CMV infection. So they have periventricular calcification, they have chororetinitis, but instead of having hydrocephalus, they have microcephaly. So you want to watch out for those three guys. Very important congenital stuff that they commonly test. So the next one is Naegleria fowleri, CNS infection that are caused by protozoa. This one is specifically an amoeba. Very easy. So how do you get this? I think that's the first thing to talk about. How do they get this infection? So this amoeba typically um, occurs or exists in fresh water. So people that are swimming in fresh water, they can get this infection. Now, when they get exposed to fresh water and they are swimming there, they take in the flagellated form. How do they take in the flagellated form of this Naegleria? They are going to inhale it through the nose. So you cannot swallow Naegleria fowleri containing water and develop the infection. No, it has to go through the nose. So once the flagellated form enters through the nose, it converts through the trophozoite. So you guys might not need to know all those conversions. I'm just explaining so that you guys can understand it. So you might not need to learn how it changes. It's just a presentation and the mode of acquisition of this infection that is important. So when the trophozoite change, the flagellated form change to the trophozoite, they are attached to the olfactory nerve. So the olfactory nerve, it now ascends along that olfactory nerve through the cribriform plate, then to the frontal lobe. So once they get to the frontal lobe, they have got into the brain. So they invade both the brain parenchyma as well as the meninges of the brain. So they cause a rapidly fatal meningoencephalitis. So encephalitis because it has affected the brain parenchyma. Meningo because it also touches the meninges. So how would they present? So these guys will have both features of meningitis and encephalitis. So meningitis, they are going to have fever, headache, neck stiffness, photophobia. Then because of the encephalitis component, they start having cortical issues. So they can be hallucinating, can see personality changes, difficulty moving, difficulty talking, you know, brain function. So that is, and it's very, very fatal. So it kills people fast. If you try to do analysis of the CSF on microscopy, you are going to see your amoebas there. They are going to be there in the CSF. So once you are seeing amoebas in CSF, someone that's having cerebral presentation, what you are thinking of is Naegleria fowleri. Very, very important. Naegleria fowleri. Naegleria fowleri. Amoeba that causes meningoencephalitis. So what do we use to treat it? Amphotericin B. So amphotericin B is the antifungal that is proven to be effective against the treatment of an amoeba. That's like coincidence. So what is the major drug that we use to treat amoeba? Anybody? Can we remember? So somebody has amoebic liver abscess. So what drug do we give that
Is
person?
it not metronidazole?
You give the
Is
person
it not
metronidazole.
metro?
You give the person metro.
Okay.
So to clear off um the cyst within the GI tree, GI tract,
Cysts. Yeah.
so what do you now give? So what do you give for that?
Paromomycin.
You give your
Paromomycin.
you give your paromycin or your hydroquinone. So your metronidazole is going to help you kill off the trophozoites of the amoeba that is causing the invasive infection. While the cysts that are differentiating into the trophozoite will be taken care of by the paromycin. Yeah. So also noted that one of the usefulness of amphotericin B is to treat Naegleria fowleri. Don't forget. Don't forget. Not metro, but amphotericin B. Yeah. In people that even survive, no, because it's very fatal. Most of them will die. They will die.
Dr. Babali,
Yes, Dr.
quick
Eden.
one. Before you move, the whole heterophile antibody thingy,
Mm-hmm.
is it only EBV that is positive? Only? Is it the only one?
I can't say, this we have so many things, but what I used to know is that it's specific for EBV. Once you have a positive test, it's likely to be EBV. So, I can say
Okay,
that it's the
thank
only thing
you.
now, and we check it's not only, but most of the situations, when I've all the things I've read, all the questions I've solved, once you see positive heterophile,
Yeah,
it is EBV. It is
it's
EBV.
EBV.
Yeah,
Okay.
it's EBV.
And I think for USML is EBV. All right,
Yeah,
thanks.
yeah.
Thank you.
Okay.
Please,
Trypanosoma
what did you say about this fidaromycin again?
no, paromycin, paromycin.
Aromo, intestinal ones.
Yeah, so we kill off the intestinal cysts of the amoeba. That's the what's anti-amoeba histolytica. No, I'm just trying to incorporate that one into this Naegleria. No, I'm just trying to refresh your memory. Do you understand?
Okay, okay.
Yeah. So
No,
trypanosoma,
Nigeria doesn't have anything to do with the GIT now. Nigeria is just
no,
the
it doesn't have anything
Nigeria
to
is
do.
just CNS.
Exactly. It has nothing to do with GIT.
But it's an amoeba too.
It's an
They are
amoeba.
both amoeba.
You get the idea. So that's why they said
Yeah.
you will see amoebas too in the CSF. So that should read our mind towards Naegleria fowleri. Yeah. So the last one, Trypanosoma brucei. So this one causes African sleeping sickness. We are very familiar with this one. So once we hear about the trypanosomas, the typical species or the typical form in which they cause infection can either be trypomastigote form or the amastigote. So we are thinking about Trypanosoma brucei, Trypanosoma cruzi. We'll get there. We'll get to cruzi. Cruzi is Chagas. Brucei is sleeping sickness. So they can have both the trypomastigote form and the amastigote. So the amastigote is the one that you find in the tissues that is causing the problem, while trypomastigote is the one that is differentiating into the mastigote. But you typically have that one in the blood. That is it. Now, how do you get Trypanosoma brucei? We are familiar with this. Setes fly. So setes fly just bite somebody, inoculate the trypomastigote into the blood, into the skin, goes to the blood, proliferate, change to the mastigote. A mastigote will start going to the tissues and be causing problem. So what is it? It actually occurs in two phases. So the first stage, you just have fever, you have malaria, lymphadenopathy, loss of appetite, body weakness, normal constitutional symptoms. That's what you have in the first stage. Now, there's something about the fever for Trypanosoma brucei. Now, we are not talking about Borrelia recurrentis here, because Borrelia recurrentis can also cause relapsing fever. But Trypanosoma brucei can also cause something that looks like you're relapsing or you're recurring fever. The reason for that is due to antigenic variation. So what do they mean by antigenic variation? What happens is that they have something. We should not don't let us bother about the name of the antigen. We should just know that there's an antigen on the surface. So now what happens is that with time, as they develop and they reproduce and they give rise to their next progeny, those progeny will change the antigen. They don't maintain the antigen, they change it every time. So that means that if you have a particular set of Trypanosoma brucei infection now, and they have these antigens on their surface. What the immune cells will do is to respond to them by producing antibodies that are specific to those antigens to neutralize them. But it's always like these guys, these Trypanosoma, are one step ahead of the immune system. How? Because by the time your immune system are trying to respond to this generation, that generation has already divided to another generation, and that next generation has changed their own antigen, surface antigen. So that means that the antibodies that are produced to respond to the first generation cannot take care of the second generation. So that means that this first generation, they will cause fever. The antibodies will come, will neutralize them. The fever will stop. But those guys have already left some progeny. They have changed their own antigen. The white blood cell cannot respond. The antibody that have been produced against the first set cannot respond to the second cell. So the second cell will colonize the blood again and they will cause a fever. So by the time the white blood cell is now trying to produce antibody that is complementary to those antigen, those ones too, they are reproducing, they are giving rise to another new cell. They are changing the antigen. So they are always a step ahead of the white blood cells or the red blood of the immune system rather. So you notice that the fever will be recurring. It's coming, it's subsiding, it's happening again, subsiding, happening again, subsiding, happening again. It's very typical of Trypanosoma brucei. So by the time it gets to the second stage and you have the trypomastoids now playing around the blood, disseminating to the CNS, they start causing some CNS manifestation. So what do they cause? Start having headaches. You have change in the circadian rhythm. So these guys will be very somnolent. They'll be very dizzy. They'll be sleeping during the day. When you have changed the circadian function of the hypothalamus, when they are supposed to be sleeping at night, they are sleeping during the day. So that's one clincher. Someone that is sleeping during the day and it's excessive because of the change in the circadian rhythm, the biological clock. And they are feeling dizzy, they are somnolent, they are comatose, they are feverish. You are thinking this is likely, especially in an African environment, you are thinking this is Trypanosoma brucei. So if you do your blood work, you are going to see your trypomastoids in the blood smear. How do you treat? Because we've said it, two phases. First phase of infection of the blood, second phase when it gets to the CNS. Yeah. So the one in the blood, how do you cope them? You give Suramine. So Suramine will help you take care of, if you are noticing trypomastoids in the blood without any CNS problem, you know, okay, what you want to give that person is Suramine to take care of the blood-borne issue. But once you are seeing that the person is already having coma, somnolence, there's affectation of the brain, so you want to give Melarsoprol. So you guys will get used to this name. I think these names are sweet. This one is not too hard. By the time we start talking about Nifurtimox and all those those ones are very controversial, but Suramine and Melarsoprol is a little bit kind of sweet a little. So Suramine for the blood one, Melarsoprol for the CNS. Don't forget. So let's look at the way they look like. So yeah. So the image you have on the 2022 version is actually better because they showed us multiple ring enhancing lesion, which is typical of Toxo. But here we are only seeing one. So we can see this ring enhancement. Can we see these guys?
Yes.
Yeah, although it should be multiple, you are thinking Toxo. So this guy has been exposed to cats.
So if we see one like they are showing us in this image, we should
What?
not pick those ones. So if we see one,
Yeah.
I said if in our exam, if we see one like they are presenting in this image, we shouldn't pick those right?
No, I'm not saying you should not pick Toxo. You look at this trail. You look at the history to now nail it. So, if they tell you that this person is having a pet, you get a pet. They are likely tilting your mind towards cats, and they are generous enough to tell you that it's even a cat. Or they tell you that they gave birth to the baby and they notice chororetinitis, intracranial calcification. They might show you the X-ray that's showing intracranial calcification, or what's it called? Intracranial calcification, chororetinitis, and hydrocephalus.
Dr. Palos.
You know that is Toxo. So yeah, so I feel that city, Dr. Zulian, is not going to stand alone. So there'll be some components in history that will help you nail it. So they can tell you that although HIV will be common to both of them. So someone that has HIV can have both primary CNS lymphoma and toxo, but they will always give you something that will help you nail, any of them.
Okay.
So, but in
So you
usual,
were saying.
in most setting, your toxo is multiple, your CNS is single. Do you get it? But it's not like your toxo 2 cannot be single. So it's not an absolute rule. So that's why you need to
Yeah.
marry it with your history. And most of the time they'll give you a clincher that can help you separate both of them. They usually say it. It's very difficult. You can check it. It's very difficult to separate toxo from primary CNS lymphoma. They are very fantastic differentials of one another. So that is that. So this should be the amoeba of the this should be the tachyzoid. So this is tachyzoid of toxo. It's unlikely they will just give us tachyzoid and ask us to make diagnosis. No. Yeah, because anything can look like this. Yeah, so this is the amoeba for Neisseria, for the Naegleria rather. So these are the amoeba looking greenish like this. So most of the time they will not even show you CSF analysis microscopy. They will give you the history. They will tell you the person is swimming. They will tell you the person is swimming. That's what they will tell you. The person is swimming, is having convulsions, having seizures, having cortical problems, Then they will now tell you that when they did the CSF analysis, they saw amoeba. That's what they will tell you. So they cannot tell you what's the implicating organism or what's the treatment. So you already know what to pick. This is your trypomasculoid for Trypoxoma brucei. So this is what it looks like. All these things are very, very similar. Very similar. So this is exactly where you see the trypomasculoid of brucei. So most of the time, you are not, relying on only your blood smell. So you are looking at your history that can help you nail the diagnosis. Yeah, so let's talk about the dermatologic ones. So the dermatologic ones particularly just includes 2. Plasmodium, okay, not it's 2. Yeah, so it's not okay, majorly 2. Plasmodium and Babesia. So Plasmodium generally causes malaria. So you guys already know how malaria presents. They have cyclic fevers, they have so cyclic fever, depending on the strain of the malaria that is causing the problem. Is it P. malariae? Is it Vivax? Is it Falciparum? So that will tell you the cyclicity or the periodicity of the fever will guide you towards the particular species of the plasmodium that is causing that malaria. So, but the normal typical presentation, they have fever, they have headache, they have malaria, loss of appetite. So, in severe cases, they get anemic. So, when there's severe parasitization and there's so much hemolysis, they are anemic. There's so much hemolysis, you have consumption of those fragmented cells by the spleen, the splenomegaly. So in some cases too, there can be hypoglycemia, particularly when there's affectation of the liver now. So gluconeogenesis is also impaired, so there's hypoglycemia. So you guys know the consideration of findings in severe malaria is a lot. They can have kidney, AKI, thrombocytopenia, so many. They can even have BIC, so many problems. Yeah. So what's the treatment? What's the transmission pattern? So Anopheles mosquito. So the female Anopheles mosquito bite can inoculate the Plasmodium organism into the body. So what do we use to treat? Before we used to treat malaria with chloroquine. Yeah. But we now have some forms of Plasmodium that are now resistant to our chloroquine. So you want to give other agents like mefloquine, you want to give doxycycline, you want to combine atovaquone with progranil. So we usually use this atovaquone progranil combination, particularly progranil in people that are pregnant. I think we have, is it not that one that, what's the other name that we call itself when we give all these pregnant people? There's another name we call this program. The what? What?
ITP, intermittent prophylactic for malaria.
Yes, IPT, but I think
sulfatoxin, pyrimethamine.
Yeah, I think
is that what you're trying to remember? It's ITP. I used to say during ANCU.
Yeah, this Bugani has that. Don't worry, I remember. Yeah, but it's ITP. It's IPT. Yeah. So, Progranil and atovaquone, doxy,
or Fancida.
Yeah, I think it's Fancida.
Fancida is sulfatoxin pyrimethamine.
Yeah, Fancida.
Okay.
Fancida is like, that's the brand name for sulfatoxin pyrimethamine.
Yeah. That name. There's another name. I don't forget. Don't worry.
I think I'm maybe don't worry, when I remember, I think
Now, you do this thing to you people.
Don't mind me. I was not very serious in posting, Jerry. Don't mind me. Yeah. So if life threatening, and that's the usual one that we treat here. So you want to give intravenous quinine, although we don't give quinine here like that. We give artesunate that the person will be alright. So, but abroad they might want to be using quinine. So before you give quinine, you must always assay for your G6PD deficiency, because you know that quinine is one of those so anything that contains quinine, any quinine formulation can trigger hemolysis secondary to G6PD deficiency. So you want to rule that out before you give your quinine. Yeah. So what are the types of the malaria? The falciparum. So we have the malaria. This malaria is the most benign. It's very, very calm guy. It doesn't cause severe infection. It has predilection for affecting the old red blood cells. So it doesn't cause very serious damage. Its own periodicity is 72 hourly, which is a quartan pattern. So we need to talk about that life cycle. These guys are very wicked because they are not teaching us the life cycle, and they're asking us questions on the life cycle. Have you know Dr. Oluwatobi?
Yes, now.
You
They're
see,
asking us questions on life cycle, and they are not giving us pictures of
the stuff.
So guys, I'm very sorry I don't have an image, but I think I'll try to use an
And should I drop an image on the group?
Yeah, so you can drop that image on the group. It's very easy to get. So drop the image. Thank you, Dr. Toby. So everything starts from the female Anopheles mosquito picking up the male and the female gematocytes. So they pick it up. When they pick it up, the gematocyte will now differentiate into the oocyst. So they lay down the eggs. The eggs will develop into the oocyst. So the oocyst will now transform into the sporozoid. So the code there is just for you to always remember that sporozoid is what is inoculated into human being. So if the female Anopheles mosquito feeds on human blood, what is going to inoculate into that person will be the sporozoid. One thing about malaria is that they have affinity for the liver. Once they get into the blood, the sporozoites always find their way into the liver. So it means that someone that doesn't have liver cannot develop malaria. That's the meaning. So they go to the liver and they start, the exoerythrocytic stage. Ah God, my battery is running down. Yeah. So they start the exoerythrocytic stage. So now, depending on the species, so someone that have the vivax and the ovale.
It's on the page now.
Okay.
It's on the page now.
Thank you.
Thank you.
Yeah, thank you, Dr. Tu. So we can see that the sporozoid is being inoculated into the liver. So once the sporozoid gets to the liver, depending on the particular Plasmodium species, so if it's Plasmodium vivax or ovale, this one actually forms a dormant form in the liver. So what is that dormant form called? The hypnozoid. So the sporozoid is going to go to that hypnozoid, and the hypnozoid will be dormant like that. Now, that's one thing. If it's not vivax or ovale, if it's malaria, falciparum, they don't form that hypnozoid. So their own sporozoid is just going to differentiate into hepatic schizoid form. The hepatic schizoid. Now, when the hypnozoid for vivax and ovale becomes reactivated, they can convert to the hepatic schizoid too. So from the hepatic schizoid, they now go to the merozoid. Now, this merozoid is the bad guy. The merozoid is the one that will go and attack the red blood cell. So once the schizoid differentiates to the merozoid, they leave the liver. The merozoid will now go and attach to new red blood cells. Now, if it's falciparum, they have affinity for very fresh, young red blood cells. If it's malaria, they want the old guys. So falciparum is more malignant compared to all of them. It's the most malignant. So, it's the most malignant. So they will attack the red blood, the fresh one. They will now start undergoing the erythrocytic stage rather. They start undergoing the erythrocytic stage. So once the merozoid attached to the red blood cell, it will transform into the trophozoid. So the trophozoid is a form that we see when we do our blood smear. So we're going to see the trovozoites that will appear like microphone headphones, or it can appear as majorly headphones. That's what we see. Now, that trovozoite will now differentiate into the erythrocytic schizoid. So erythrocytic schizoid, schizoid always goes to merozoite. So it will go back to the merozoite. And when it gets to the merozoite, it will rupture the red blood cell, releasing the merozoite so that they can affect new blood cells. So by that way, they are embolizing the blood and they are causing hemolysis and anemia. That dissemination also releases interleukins and all those things that brings about the fever. Yeah. So now imagine that cycle is happening 72 hourly. That's the characteristics of malaria, 72 hourly. So that's why the fever pattern is usually quarter. So you tend to have that fever coming down, coming up again every 72 hours. So what do you see? Blood smear for malaria. You see the trovozoite ring that is having headphone shape. Where is it? So you can see, you guys can see that this is looking like headphone. We can see this. Hello, guys.
I'm coming at Dr. Babale. Yeah, I was on the class group. What did you say we should look at? Okay, okay.
The slide B, headphone, Abi, the one that is double. Yeah, so once you see that, you are thinking of malaria, either falciparum or malaria. Now, another thing in addition to this that will be present for the what's it called? The Vivax is that we are going to see what we call the Schaffner or the Schaffner bodies or Schaffner striplings. So they are like eosinophilic granules that is present in addition to trophobos. So you guys can see this dark spot stuff. That should be slide A. Yeah. You can see this dark guys that is here too. So once you see that, you know that the strain of malaria that you are battling with is the one that is caused by Vivax and Ovalin. Yeah. Now let's go back to how you differentiate those guys. So we said the periodicity of malaria is 72 hourly. It takes time, 3 days. Yeah. But that of Vivax and Ovalin is 2 days, 48 hourly, 30. And they are the ones that have the dormant form in the liver, the hypnoxite. So that means that even if you have killed off all the one that is in the blood, you have to take care of the one that is in the liver, because that liver one can easily move to the hepatic schizoid that can go to the merozoite and attack the red blood cell. So it's like a reservoir. So you must factor treatment of that reservoir, in the treatment. Yeah. So you might want to give them mefloquine to help you take care of that hypnoxite in the liver. Yeah, or primaquine. So majorly it's primaquine that they give. So you give primaquine to take care of the dormant hypnocytic form in the liver. Primaquine. Yeah. So don't forget that about the Vivax and the Ovalin. They are the one that form the hypnoxite. They are 48 hourly in terms of their fever periodicity, and they have the Schaffner stripling in the red blood cell. So let's talk about the last one, falciparum. So falciparum doesn't follow the normal periodicity one. It's irregular. It can decide to take 1 day. It can decide to take 3 days. It's because it's very severe. So we are always having constant bursting of different stages of the red blood cells in your falciparum. So they are constantly boxing here and there. So that's why the fever pattern is irregular for falciparum. It kind of causes every parasitization. So those parasitized red blood cells are kind of deformed. They are rigid. They can occlude different capillaries. So when they occlude capillary of the brain, they cause ischemic injury to the brain and can bring about cerebral malaria, which is associated with, focal neural deficit, seizures, loss of consciousness, and the likes. They can occlude the vessels to the kidney and cause AKI. They can occlude the vessels in the lungs and cause pulmonary edema. So they can cause they can go to the liver and cause damage in the liver, and they can bring about jaundice. They can occlude the vessels in the spleen and cause splenomegaly. So that's why the typical severe malaria is caused by Plasmodium falciparum. So you see the headphone shaped red blood cell, these ones that we are seeing here, you see that's the image B, right? So you see it, and you are going to see crescent shaped dermatocytes. So this is the crescent-shaped dermatocyte here. Can we appreciate these guys? So we can see this, right? Crescent shape. So moon, like half moon shaped dermatocytes. So dermatocytes are the ones that we are picking that is forming the oocyst, which is now forming, the sporozoite. Hello guys. Are you with me?
Yeah.
So two things that you see to help you nail falciparum. So you see the headphone trophozoite, then you now see the crescent shaped dermatocyte. Dermatocytes are those ones that are giving rise to the oocyst. They're like the gametes. Yeah. So that's that about malaria. That we already talked about the treatment. You want to give chloroquine if it's sensitive. If it's not sensitive, you want to give mefloquine. You want to use your progranil and tobacquinone. You want to use doxycycline. Yeah. And remember the treatment for the hypnotic stage of Vivax and Valley. In addition to giving your mefloquine or your quinidine or artesunate, you must always have your primaquine to take care of that hypnotic stage. And remember that primaquine is also one of the triggers for GCPD. So before you give primaquine abroad, we do GCPD assay. We don't do that here, but abroad you have to do your GCPD assay. Yeah, very important. The last one is Babesia. So by way of geographical location, you can separate them. You are seeing all these things that look like malaria, but in northeastern US, north central state of US, you cannot be thinking of malaria until you have done your basic investigation and all you are saying is pointing towards malaria. That's when you can be sure. So babesiosis or babesiosis rather should be one of those things that you want to consider. But what are the typical ways that they present? They have fever and they have hemolytic anemia. So their own hemolytic anemia is very bad because the way this babesia infect is that you are going to have 4 different merozoites joining together, forming what we call the Maltese cross. They will fill in the red blood cell and they will hemolyze it. Just imagine 4 merozoites attacking one red blood cell. They are now forming gang on top of one red blood cell. So it's going to be very bad. Can you guys see this? Can you guys see this? So this is the merozoite conjoined together in 4 units. Yeah. So this is a multi-cross pattern, and you can see one of the ring form, the trophozoite form. So the trophozoite is actually called immature ring form. So from the trophozoite they go to ring form proper. So they are like the same thing. That's why I don't waste my time separating them, because trophozoite is like immature ring form. So they are like the same thing. So this is a ring form or the trophozoite. This is the multi-cross, which contains aggregation of the merozoites. Yeah. So they cause fever, they cause hemolytic anemia. Don't forget that. They pass red, that color urine. They have hepatosplenomegaly. So, that's that about. But once you remember your fever, your hemolytic anemia, you are safe. And they can also present with sepsis, particularly people that are asplenic, because it has been observed that the spleen is necessary to clear the red blood cells that are infected with this Babesia guy. So any red blood cells that are infected with the Babesia, the spleen, if it's functioning, can help us mop them out. But anybody that is asplenic, maybe from sickle cell anemia or maybe from trauma that you have to remove that spleen, they can be predisposed to the more severe form of babesiosis. So they can even go into septic shock. So that's one way they can present. So they have fever, hepatosplenomegaly, hemolysis, you know, and in severe cases they can have symptoms of septic shock. So what's the vector? This is not female Anopheles mosquito, but the Ixodes tick. So in addition to anaplasma, that we said that is going to present with a morula in what? Anaplasma. Morula in what?
Morula in granulocyte.
Yeah.
Monocyte.
Morula in granulocyte. While erythrosis is going to be morula in monocyte. Yeah. Fantastic. So in addition to that Ixodes tick, in addition to being a vector for Babesia, it's also a vector for Borrelia burgdorferi that cause Lyme disease and Anaplasma that cause anaplasmosis. How do you identify them once you see this 4 ring on your smell? This is the picture that they usually bring out for Babesia. Once you see it, you know what they are talking about. So the treatment is actually the 2 A's, atovaquinone and azithromycin. Atovaquinone and azithromycin. So Guys, it's so bad that my battery is going to go, but I have 32% left. But let's just continue. Let's continue. So the other ones are the visceral ones. So the two viscerals, Trypanosoma cruzi, Leishmania. It's very easy to make diagnosis of Trypanosoma cruzi because the question is going to give you all the clinchers. Trypanosoma cruzi is transmitted by the triatomine insect, the kissing bug. So not Tethys fly now, but
Infectious mononucleosis, Abi. Not that one.
no, not Tethys fly. Tethys fly is for Trypanosoma brucei. This is
Brucei.
You said kissing disease,
kissing bug,
Abi.
kissing
It's
bug.
Oh,
fly.
okay.
Yeah, kissing disease is
No.
different. I did not say kissing disease. I said kissing bug. Kissing bug.
Because that one is infectious mononucleosis.
Yeah, kissing disease is infectious mononucleosis. Yeah. So this is kissing bug, triatomine insect. So what they do is that they can bite. When they bite, they are going to inoculate their fecal matter into that bite region, and they will find their way to the blood cells, to the blood vessels, and disseminate into the body. That is how they work. So the typical bite site is around the mucosa, maybe the mouth or the eye. Those are the areas where they typically bite. So they bite around the mouth or the eye. So if this insect bites somebody in the eye, the kissing bug is going to release the trypomastigoid form of the Trypanosoma cruzi. You know, when we are talking about Trypanosoma brucei, we said both of them, the form that they exist is actually maybe the trypomastigoid form or the amastigoid form. Yeah.
Mastigoid.
Yeah, so trypomastigoid is what you find in the blood. Amastigoid is the one in the tissues. So it's going to inoculate the trypomastigoid into the blood. So you know, the trypomastigoid is in the feces, so they will enter the bite side and they will enter the blood vessel, and from there they're going to the blood. But if it's biting at the highs, so that region is going to undergo inflammation. So there's going to be periorbital edema, there's going to be conjunctivitis. That's what we call the Romana sign. Once we are moving it, they know, God, this guy is good. When you say Romana sign, Trypanosoma cruzi, unilateral periorbital swelling due to inflammatory response from inoculation of the Trypanosoma cruzi trypomastigoid from the kissing bug bite. So when they bite at the eye, the first acute symptom is the periorbital swelling, Romana sign. But you might not have the Romana sign when it bites at the mucosa of the mouth. You might not have it. So it's just find its way into the blood. And it has predilection for three areas: the heart and the GI. But what part of the GI? The esophagus and the colon. So it causes big things. Big things. Dilated cardiomyopathy, megacolon, megaesophagus. How? So the simple explanation, there are so many theories, but the simple explanation, particularly for the megacolon and the megaesophagus, is that you guys remember that we have plexuses within the GIT. So the mesenteric plexus and the
Back
the Hallback and the Messner. So your Hallback particularly helps you for motility. Your submucosal, that one is more for secretion. Yeah. So there's a damage to particularly the Hallback plexus or the mesenteric plexus. So there is impaired peristalsis. There's also damage to the smooth muscles of the wall of the GI. So the GI is kind of constipated and distended. That's why there's distension of the colon, because there's atrophy of the smooth muscles there, and there's denervation from damage to the Hallback plexus. So this is a form of acquired aganglionic megacolon. So if somebody has congenital aganglionic megacolon, what's our diagnosis? Anybody? Congenital aganglionic megacolon. What's our diagnosis?
Hirschsprung.
Hirschsprung disease. You guys remember the squirt sign?
Please, is Dr. Why network breaking, or is it my own? Can you guys hear him clearly?
Yes, we can. Can hear him clearly.
Yeah. Dr. Oluwatobi, can you hear me now?
I can hear you, but you know this sound that it makes.
I think it's your own network.
Don't worry. I'll connect to it, but I will do some. Thanks.
Okay. So let's just ignore trypanosoma, the Hirschsprung for now. Yeah. So let's focus on this guy. So we've understood the way they cause the dilatation of the esophagus and the colon is actually due to denervation as well as damage to the smooth muscle. So that's why they become distended. But you guys should watch out. It's not only these guys that can cause megacolon. You can have toxic megacolon, particularly in infection setting. I know you guys will remember toxic megacolon.
Like Clostridium difficile.
You are doing well.
Difficile.
Clostridium difficile can cause toxic megacolon. An autoimmune disease which can cause toxic megacolon. Anybody, autoimmune in the GI that cause toxic megacolon. It's one of the clincher. Once you see it, in fact, ulcerative colitis. Ulcerative colitis. Ulcerative colitis causes toxic megacolon too, although the mechanism is not well known. That's one way you can separate it from your Crohn's. Ulcerative colitis causes toxic megacolon. It can rupture easily. There'll be mad, bloody diarrhea, and peritonitis. Yeah. So, although someone that have toxic megacolon without peritonitis, so you might not see the guarding, you might not see the rigidity, but you can see tenderness, you can see abdominal distension. It's likely to have developed toxic megacolon. But when peritonitis sets in following the perforation, that's when you now start having the abdominal rigidity, the abdominal guarding. Once you see guarding rigidity, pod-like rigidity, that is peritonitis. It has perforated. Yeah. So megacolon, megaesophagus, dilated cardiomyopathy. So they go to the heart. They cause inflammatory response. So there's a lot of inflammatory response there with eventual fibrosis, which will eventually lead to dilatation of the heart, and they will present with symptoms and signs of heart failure. Yeah. So it's very common in South America. This is a South American issue. In fact, your Calaza, which is your leishmaniasis, and your trypanosoma cruzi, they are South American problems. That is it. Don't forget about that. Don't forget. Once you see Argentina, you see Brazil, you know what they are talking about. This is, your trypanosoma, your leishmania. So what do you see? You see your trypomastigoid. So the form that's causing all this damage is actually the amastigoid form. Yeah, that's the one that you find in the tissue. So what do you use to treat? Your benznidazole. So the way I remember it is I just substitute it. Metro Benz, benznidazole, and Nifurtimox. I know it's not easy to palm this name. I think that's the only one that we really need to.
Dr. Babawale, did you just say the one that is causing all the symptoms is the amastigoid now?
Yeah. So the amastigoid is the tissue form. You remember? So that's the one that is entering the tissues and causing this inflammatory damage. You get. But the one that is in the blood, is the trypomastigoid. So your trypomastigoid can proliferate or it can differentiate into the amastigoid that will go to the tissues and cause the problem. Do you understand the question?
Okay, yeah, I do. But does that occur to everything? Because I've been thinking that is the one that is in the blood that is causing the.
Yeah, it occurs to everything. It's the same
So
way.
it's the one that is in the
everything.
tissue. Okay.
Yes.
So any symptoms that is in the tissue is the one that is in the tissue that is causing it.
That's causing the problem. Exactly. Yeah.
Okay.
So they just
It's only mastigoid that is in the tissue.
Exactly. So
Mastigoid
is the tissue form. That's the tissue form. Yeah. So that means if you are doing your blood smear, you'll not be watching out for your amastigoid like that. It will be your trypo that you'll be watching. But the exemption is for leishmania, because in leishmania, once they come in, the macrophages are going to engulf the amastigoid. So the trophomas the there are actually many forms for this leishmania. So it's going to come from the promastigoid to the trypomastigoid to the amastigoid. So it engulfs your promastigoid, and it will keep replicating and differentiating to the amastigoid. So the differential to diagnose the best way, or the clincher for your leishmania is using the macrophage containing the amastigoid. So that's the way to palm it. You just remember, which other organism do we remember macrophage when it comes to diagnosis? I want to see if you guys can remember.
TB, Legionella.
No. Like, that's not what I mean.
What are you asking?
So engulf inside macrophage,
exactly. If you are saying that, Dr. Toby, what we use to diagnose leishmania is not macrophage. Is what?
Leishmania.
Antigen detention in the urine. That's Legionella. You get?
Oh, you said Leishmania, not Legionella. Okay.
Like what I'm asking is another organism that when you want to make the diagnosis, you look at for some features in the macrophage. I'm not typically asking for organisms that are intracellular. Sure you get? Like that macrophage feature helps in the diagnosis. There's another one that we talked about yesterday. That's where I want you guys to
It's like the second one of the other one. I cannot remember the name.
histoplasma. Histoplasma.
Oh, ectoplasma.
Eh?
Oh, Marco, that's true. Cave disease.
Cave disease.
Oh, that's
That's the
true.
way you guys can be putting all these things together so that it will not scatter. Marry them together. So once macrophage comes to your head, separate the intracellular organism. It's not more about the intracellular that I'm talking about now. It's about what are those things that you have to look for in the macrophages to make your diagnosis. Number one, histoplasma. Once you are seeing yeast cells within the macrophages that are tiny compared to red blood cell, they are not up to the size of red blood cell, that's your histoplasma. You are seeing them in Missouri, in Ohio, in what's the other area now? I can't even remember now. Yeah, those areas. And
Mississippi,
Mississippi,
Ohio.
Mississippi. Thank you. I know you are there, so you remember. Yeah. So so then in caves, that is your histoplasma. That's your histoplasma. So yeah. So leishmania too, you look out for the amastigoids engulfed within the macrophages. Don't forget that leishmania. We are going to see a picture, so it will stay. Yeah. So what is the mode of transmission for the leishmania? Sandfly. So sandfly, um, phlebotomos. I think that should be phlebotomos. Yeah. So sandfly is one that transmits the leishmania. So they introduce the bromastigoid into the blood, following the bite. But we have two forms of leishmania. Very easy, very easy. Cutaneous and the viscera. The visceral leishmaniasis is the calaza. That's a bad one. Cutaneous is not, it's just cutaneous. They just bite, inoculate, they cause inflammatory process there that will evolve into ulcers. So you are going to see some very terrible ulcers that can undergo some fibrotic replacement that's very disfiguring. The ulcers are very big. You can check it online, you see it. I don't think we have ulcers. Yeah, so we have one here. You can see this. So this is an example. But guys, you know that they cannot show us this only and be asking us for diagnosis. There's so many things that can cause ulcer. Here again,
Mm-hmm.
I'm going to put some things in the history that will help us. Maybe the location, South America, or they will tell us the finding following, the blood work. So they did microscopy, they are going to see. So if you do this tissue biopsy now, if they biopsy this tissue now, they can see blood within that area that is, the macrophages there that is containing the amastigoid. So you know that okay, this is leishmania. This is leishmania. So that's the cutaneous form. The visceral form of leishmaniasis is just affecting the visceral organ, particularly the liver and the spleen. So guys, I hope you guys can see my battery is going to go off soon. Oh my god. Hey, sorry about this. I'm definitely going to go to my house so that this kind of embarrassment
We can't wait for you to come over. All this your complaint.
like it's very terrible. Like you can imagine. See my life now. Yeah. So viscera affect the liver and the spleen. So what they do is that they just occlude the sinusoid of the liver and the spleen. So you are going to have blood congesting in that area. It's going to be very big. Hepatosplenomegaly, one very distinctive presentation. That's one thing that's peculiar to viscera. The liver and the spleen will be very massive. It will be very big, and it can also cause damage to the blood cells within the marrow. So they cause, damage to the red blood cell, white blood cell, all the components, platelet, everything. So they cause pancytopenia in addition to causing the hepatosplenomegaly. So how do we treat it? Amphotericin B and sodium thibogluconate. So you want to remember those two things. There's no code. I don't really know. You see that they themselves, they could not come out with any code. They just left it empty, nothing to guide us. But as you guys are reading it, it will stay. It will stay. So amphotericin B also works for Naegleria, which is an amoeba. We're also using the amphotericin B here for leishmania. The normal region where we use the normal disease that we use the amphotericin B for is what? We use it for.
Systemic candida.
Yeah, so someone that has, systemic issues, systemic candidiasis, or someone that has this guy, cryptococcus, you add it with your flutocytosis, and you add your fluconazole.
Um,
Yeah, so amphotericemia and sodium stibogluconate, unlike trypanosoma cruzi that use nifotimos or your benznidazole. Nifotimos or benznidazole. Here, amphotericin B or sodium stibogluconate. Your macrophages containing the mastigoid. So, two forms, visceral and cutaneous. Visceral, big spleen, big liver, bone marrow suppression. Cutaneous is just skin ulcers. Sandfly is a culprit. Yeah. So let's just stop at trichomonas. So the sexually transmitted one, trichomonas vaginalis is the only one. So it causes vulvovaginitis. So that means there's an inflammatory response here. Unlike in bacterial vaginosis, there is no inflammatory response. There's no inflammation in bacterial vaginosis. There's no inflammation there. It's not painful. It's not itchy. You just see your gray white discharge. But yeah, there's inflammation. There's a vaginitis. So it's itchy. It's burning. And there's a foul-smelling, terrible foul-smelling greenish discharge. So you don't confuse it with the Gardnerella vaginalis that we've talked about that is causing bacterial vaginosis. Yeah. So it's sexually transmitted. It doesn't form any cyst. So that means that it has to move from, the GI, the genitourinary tract of one individual to another individual like that. It cannot survive outside. So during intercourse, they spread it from one person to another. So we've talked about the trophozoites, how they look like. We said that it looked like trophozoite of what organism? Can anybody remember?
the trophozoite of this Trichomonas.
Yeah, resembles trophozoite of what? That trophozoite is also flagellated. It is pear-shaped. We mentioned it.
Yeah. Is it the one of Gardia?
Yes.
Sorry.
Yes.
Okay.
Gardiasis. That's exactly what it's going to look like. So once you see something that's looking like this, and they are saying steatorrhea, they are saying foul-smelling, bulky stool, they are saying crampy abdominal pain, that is gardiasis. You are seeing things
Gardia.
like this, and you are seeing vaginitis symptom, discharge, and all those things. You know that this is trichomonas vaginitis. If you do your
But Dr. Babali, that foul smelly, does it have to be fishy or it can just be foul smelly?
You mean
I thought it
trichomonas?
was.
Terribly smelling. Terribly
No,
smelling.
Gardia. Okay.
No, it's not foul smelling, like it's not fishy. Once you see fishy,
Yeah.
which organism are you thinking of? Fishy. What's coming to your mind?
Bacterial vaginosis.
Yes.
Vaginosis, Gardnerella.
Vaginosis, yeah. And you also confirm that fishy smell by doing your what? Which test?
KOH.
Your KOH, my
Okay.
nigga. Your 10%
Okay.
KOH whiff test.
That's one that we see club cells and stuff in Abby.
Exactly. That's why you see the clue cells.
Okay.
Your
Is
clue
it clue
cells.
cells?
Yeah. So if you do the what do we call this thing that you just put your what do we call this one GT guys? My one is now wrong to you. That's what I'll put inside the service to look at this thing.
Colposcopy. I'm sorry.
Colposcopy. Yeah. Like yeah, is it not colposcopy? No, it's not your you guys are
And
Speculum.
it's
I
your
think
speculum examination. Thank you. Our board certified consultant. Our about to be triple certified consultant. Yeah. So
I'm
what you do,
telling
you
you.
go to do speculum examination. So on speculum examination, you are going to see this punctate cervical hemorrhages that looks like a strawberry. So you know that is trichomonas. But it is not common. It's like in 10%, but we still need to know it, even though it's not common. If we do the wet mount of that specimen, that discharge, we are going to see the motile trophozoites. They'll be moving because they are flagellated. So those are the two clinicals for trichomonas. You do your speculum, you are going to see the punctate lesion. Then you do your collection of the sample, the vaginal discharge, which is greenish. You mount it in the microscopy, you are going to see motile trophozoites. Unlike in bacterial vaginosis that we are going to see clue cells. Unlike in candida that we are going to see budding pseudohyphae yeast on our mounts. So what do you want to do for someone that has trichomonas? You want to give them metronidazole. That will take care of the trichomonas. Metronidazole also works for bacterial vaginosis. But in bacterial vaginosis, you can use metronidazole and clindamycin. in Trichomonas, you can use metronidazole. You give your metronidazole to kill off that organism. You also need to treat the partner. So that means you need to do like contact tracing. Treat the partner too. Give them metronidazole and check for other STI. Yeah, because it increases the chance of transmitting other STI, trichomonasis infection. Okay, so I think I'm going to